Good afternoon and welcome to the second series of our ongoing webinar aimed to spread awareness of the COVID-19 crisis, commonly called as the second wave. The webinar is organized by the Pacific Group and I am Dr. Bhaskar Bhattacharya representing Pacific. For our guests dialing in for the first time, a very brief introduction about the Pacific Group. Pacific is a pan-Asian organization headquartered in Singapore with operations in the Philippines and India. In India, we are located in Salt Lake, Kolkata, and are known as Pacific Oncology Multispecialty Polyclinic. Pacific Oncology is a one-stop shop providing expert consultations by renowned specialists in Eastern India. More details can be obtained by visiting our website at www.pacific.in or from our Facebook and Instagram pages. In the first webinar, we discussed at length regarding diabetes post-COVID-19 infection and associated complications. In this webinar, we are going to explore another interesting topic, COVID-19 and its effect on pregnancy and the female reproductive system, antenatal effects, and infertility treatment planning. The United States had last November added pregnancy to its list of underlying medical conditions associated with high risk for severe COVID-19. This was based on a study by the Center for Disease Control and Prevention, more commonly known as the CDC, that found pregnant women with COVID-19 were at significantly higher risk for severe outcomes than non-pregnant women. The findings revealed that pregnant women were at an increased risk for ICU admission, more likely to require invasive ventilation and ECMO, which is a heart-lung bypass machine, compared to non-pregnant women who were symptomatic. But more worryingly, there was a 70% increased risk of death associated with pregnancy compared to women who were not pregnant. This trend has been observed in India as well. So, why are pregnant women with COVID-19 more at risk than their non-pregnant counterparts? Our expert panel will have a lot of these questions answered, and we are expecting to have a fantastic discussion regarding gynecological effects and COVID-19 infection. On our panel, we have Dr. Sagarika Basu and Dr. Shamapika Chatterjee, both gynecologists and infertility specialists. Co-chairing the session with me is Lieutenant Colonel Dr. Shona Kundu. We are very thankful to our panelists for giving their valuable time for this very special webinar. Dr. Sagarika will be presenting a few slides and we will commence with her presentation. Dr. Sagarika, over to you.
Good afternoon, everybody. Thank you for joining in today's session. I hope we will be able to discuss few important points related with COVID-19 infection and pregnancy and some infertility related issues. And thank you, Pacific, for giving me the opportunity to speak today. I will not take too much of a time and let's start our session. I am going to share my screen now. And so, yeah, as Bhaskar said that pregnancy has now been added to the high risk category in COVID-19 infections. COVID-19 was declared as a global pandemic in March last year. And now we have reached a stage where we are calling it as a second wave. And I don't need to talk too much about it, what implications we have seen so far.
I think there are a few generalized questions that, why, the most important question is that, what makes pregnant women more vulnerable to COVID-19? Is there a difference between pregnant women more prone to contracting COVID-19 versus pregnant women with COVID have increased risk for more serious disease?
A general rule of thumb is that pregnant women do have a similar risk. So they do not have an increased risk of contracting the infection. So their risk of contracting the COVID-19 infection is the same as general population. And so far reported cases of COVID-19 pneumonia in pregnancy have been reported as mild and with good recovery. However, we all know that pregnancy is an immunocompromised state. So the effects of COVID-19 infection has been severe or more moderate to severe, I should say, or a little bit more in comparison to general population. And it's the same with other coronavirus infections as well. So the principle remains the same, that because pregnancy is an immunocompromised state, the viral infection tends to be a little bit more serious in pregnancy. And the risk is highest in third trimester. And there has been case reports of preterm birth, but we are not sure if those preterm births were iatrogenic or it was spontaneous due to COVID-19 per se. And pregnant women with heart disease, they are at highest risk. Also, other high-risk conditions like gestational diabetes, lung diseases, etc., associated with, like in pregnant women, they are also they fall in the high-risk category as well. But per se, pregnant women with heart conditions are at highest risk of having severe COVID infections and the morbidity and mortality outcomes from that. The other aspect which has been noted in pregnant women who have had this infection, there is an increased risk of anxiety, because it is associated with not only their outcome, but with the fetal outcome as well. So anxiety, depression, and domestic violence have been reported as to be high in these cases as well. So we need to be very, very careful as gynecologists, obstetricians and gynecologists, that when we come across any woman, any pregnant woman, we need to be a little bit more empathetic and vigilant about any such problems that they might be facing, because we all know that mental health issues do have a serious implication in pregnant women as well. So a little bit more vigilance from our part.
Is there any possibility of someone who's pregnant may transmit the disease to the fetus or to the unborn child?
So this is what we call as vertical transmission. So vertical transmission is transmission of the virus or infection from the mother to the fetus or the baby during the course of their pregnancy and during the course of labor. So vertical transmission, now some newer evidences have shown that yes, it has been possible, but the proportion of pregnancies which have shown a vertical transmission and the fetal outcomes are still not quite proven. So yes, evidence is coming up that there has been few vertical transmissions, but not quite at that point that we are like discussing all these things. So the other thing is that so far there has been no recorded cases of either vaginal secretion or breast milk to be tested positive for COVID-19. So no recorded cases so far.
Okay. And Dr. Sagarika, what about, women who get positive with COVID-19? I mean, are there any complications at the time of labor? I mean, like with preterm birth or stillbirth and issues like that?
It is still a newer infection. We do not have much data, but so far we have not really found any data suggesting increased risks of miscarriage or early pregnancy loss in COVID-19 pregnancy. There has been no data suggesting that women contracting COVID-19 in their early stages of pregnancy will have any congenital birth defects in their child, which we call teratogenicity. So no data suggesting teratogenicity, but as I said, that it is like a newer infection, so long-term data is awaited. And I would like to take this opportunity to emphasize this fact that COVID-19 infection in pregnancy in early stages, it is not an indication for a medical termination of pregnancy.
Okay, so we know that, there's no data which suggests that there's risk of miscarriage or MTP or any birth defects, so only time will tell that, because this has just started and there has got to be a lot of follow-up and cohort studies perhaps, to bring these things up. So, doctor, what would be your general guideline for doctors, like those who are the frontline warriors, like specifically those who are practicing gynecology, and any specific management criteria which you would recommend for them?
So yeah, I mean, there are certain management protocols and guidelines, which I'm sure Dr. Shamapika will go through in our discussion later. I would like to highlight some general principles, general guidelines, which us gynecologists and obstetricians should follow if we come across a pregnant woman with COVID-19. So healthcare professionals should immediately notify the health department. A registry has to be maintained for pregnant women contracting, like with positive COVID-19 RT-PCR, and that will help us to record the maternal and fetal outcomes. That has to be preserved for future analysis, because that is very, very important, and that gives us an opportunity to formulate a plan, etc., in future. And general measures, general education, information and education to women that they should still be maintaining social distancing, hand hygiene, appropriate PPEs, etc. So these are the general guidelines that should be followed by ONG specialists.
So I think the idea is that, like testing is more appropriate. I mean, like one needs to test, and, like I have detailed medical history, such as travel history and history of contact and all these kind of things.
Definitely.
Now, for a pregnant woman, what would be the indications? I mean, what sort of signs and symptoms they should look out for, so that they know now it's time to probably move from isolation or like home isolation and go to a hospital setting?
Yeah, so general symptoms is the same as general population. So majority of the times, most likely the COVID-19 infection will be mild, symptoms will be mild, and women can be treated or can be observed in home isolation. But there are certain criteria which they should look out for, and be prepared to be to contact their obstetricians and for hospital admission. Things like fever more than 38 degrees Celsius or 100.7 degrees Fahrenheit, and respiratory symptoms. These are the two main symptoms that women should be looking for. And if they have any of these, then they should get an hospital admission. And what we do initially, they should be in an isolated room with monitoring of the vital parameters like pulse, blood pressure, temperature, respiratory rate, and oxygen saturation. If their symptoms are deteriorating, by all means, we can carry out chest CT scan or chest X-ray with appropriate abdominal shielding to protect the baby from radiation exposure. The fetal heart sound or the baby's heartbeat should be auscultated once daily. Consideration to betamethasone, which is a type of steroid, should be given to preterm mothers. What we mean by that is for pregnancies before 34 to 36 weeks, a consideration to steroid should be given in case there is an early delivery that helps in the baby's lung maturation, and antibiotics as per protocol. So these are the criteria so the main criteria for hospital admission is fever and respiratory symptoms.
There is a concern that, prescribing medications and therapeutic agents in pregnancy, like it's high risk. So how would you quell the concern that antibiotics in pregnant women, I mean, how safe are they exactly? I mean, how would they, should there be some concern?
Yeah, definitely. I mean, all antibiotics, we have to be careful about antibiotics, what we are prescribing in pregnancy, but there are certain antibiotics which have been shown to be safe, and there are numerous studies and evidence available for their safety measures. But there are certain antibiotics which are commonly used in COVID-19 infection, which we should not be prescribing in pregnancy. For example, doxycycline. Doxycycline is absolutely contraindicated in pregnancy. But say, for example, last year we had seen that there was a practice of prescribing azithromycin for pregnancy, for COVID-19. So azithromycin can be prescribed safely in pregnancy. So can be amoxicillin group, ceftriaxone group. There are certain groups which are safe.
Right. Okay. And what would be the signs and symptoms for an intensive care unit admission for someone who's pregnant?
So for a pregnant woman with COVID-19 infection, there are certain criteria for intensive care unit admission. as we measure blood pressure, there's a systolic and diastolic. So the systolic is the systolic less than 100 millimeter mercury, a high respiratory rate more than 22 per minute, and GCS or Glasgow Coma Scale, which is less than 15. So by Glasgow Coma Scale, I mean there are certain parameters which we measure and it gives us a score, and it involves like eye movements, motor responses, consciousness, etc. So these are all concised in a score which gives us, and 15 is normal. Anything less than 15 is abnormal. So in any like more than one of these criteria fulfills the requirement of ICU admission, and there is a severe failure criteria where we should consider delivery of the woman, which is septic shock, acute organ failure, and fetal distress, meaning the baby going into distress. So one of these should ring the alarm bell that we should be thinking about delivering the woman, because if we deliver the baby, then the physiological reserve of the woman improves a little bit, and then we can give her the optimum chance of resuscitation and all the treatments.
Right. Okay, there's a question from someone in the audience, Dr. Ranit Bag. Are there any studies on transcental movement of COVID to the fetus, which leads to birth defects?
As I said in my previous slides, that so far no data has suggested that the COVID-19 infection has shown any teratogenic effects or any congenital birth defects in women with the infection.
Okay, so another question which has come up, Dr. Shomapika, if you could take this, is there any harmful effect of the COVID vaccine on the fetus? Because Dr. Bag mentions that he actually saw a case of MTP on a patient after getting vaccinated.
Not really, because all the vaccines which we are using now are all vector, either mRNA vaccines or vector-bound vaccines, or, inactivated or killed vaccines. None of them are live vaccines. And it has been seen that only live-nated vaccines may have side effects to the baby. And therefore, all these vaccines are truly safe in pregnancy and for breastfeeding ladies. But when the manufacturers went for the trials, the phase 1, phase 2, phase 3 trials of these vaccines to be bought out in the market as an emergency immunization schedule. Therefore, the government of India is still not recommending the use of these vaccines in pregnancy. But as of now, there is no risk of transmitting the virus to the fetus, immunizing the mother in pregnancy. So you can be risked, and therefore please you should not be scared to get yourself vaccinated, especially the high-risk ladies.
Yes, but Dr. Chatterjee, there is this lingering fear, especially the vaccines in India, Pfizer and BioNTech. They have tested and they've trialed the vaccines on pregnant women, while Covaxin and Covishield, there aren't any tests. From a pregnant lady's point of view, I mean, I can't imagine how it's going to be, but, because these are not trialed and, we all know the scientific process. So what would be your advice to them that to go ahead with it?
It should be an informed consent. It should be a personal decision. But at the same time, I can allay their fears by telling them, if you could take the influenza vaccine, if you could take the Tdap vaccine, which are based on the same principle, I think in the long run, very, very shortly, in the long run, we are going to recommend vaccination in pregnancy. And therefore, if someone is at high risk, if someone is a frontline worker, someone who is more prone to infection, someone who is more prone to get an ICU admission, severe forms of the disease, I recommend that they should take the informed consent. With informed consent, they should take the vaccination, because that is going to give them some amount of protection, and the late side effects, if any, are absolutely, not to be taken into consideration, because as of now, it has been safe. mRNA vaccines, as you said, almost 90,000 ladies in USA have actually taken the vaccine in pregnancy. And even in India, there have been many ladies who have taken the vaccine without knowing that they were pregnant, and they have come out with good fetal outcome. But definitely, long-term trial, long-term studies, very large studies have not been in place for the government of India to recommend the vaccine. But all international bodies, including our FOXI, has recommended that we should advise them, we should counsel them to get themselves vaccinated.
Right. Women who are lactating, I think it's okay for them to take the vaccine. I understand. So, and I think the same argument can be held against the vaccines, like with the therapeutic agents, with Remdesivir, for example. I mean, there hasn't been like a controlled double-blind placebo-controlled trial to show the effect of Remdesivir on pregnant women versus non-pregnant women. So I think it's all a question of, like, as you said, like take informed consent and explain to the patient that, like what are the risks involved. And if the benefits outweigh the risk, then it's generally advisable with what background scientific knowledge, which we have to actually proceed with the treatment. Excellent. Dr. Sagarika, I mean, I think another thing, so once a pregnant lady gives birth to the newborn, I mean, are the antibodies passed on from the mother to the child? Is there a possibility?
Yeah, like other infections, what we have seen is antibodies, the baby, for the initial couple of months, they have a protection from maternal antibodies. Yes, they do. So for COVID-19 as well, I think there will be some protection as well. But again, it is a field that has not seen much of a research or evidence so far. But yeah, I would imagine there will be some.
Right. And also for radiological assessment, I mean, there's always this risk for pregnant ladies, who've got, a consolidation in the lungs, to get an CT scan done. So, I mean, how to avoid, like any fetal harm through this radiation, through exposure to CT?
Yeah, definitely. As I said earlier, that if a woman's symptoms are deteriorating, and if as a clinician, we feel that she should have some sort of lung imaging in the form of CT, high resolution CT scan, which is so far the gold standard in COVID-19 pneumonia. By all means, there should not be any delay in organizing that CT scan, but with abdominal shielding, what we call, so that we can minimize the radiation exposure to the baby.
Regarding this, I would like to say something. I would like to comment. Recently in the papers, it was there that one HRCT chest was equivalent to 300 X-rays. I mean, that is really outdated now. Now the technique which is being used, the ALARA technique, as low as recommended dose, that it gives only about 5 to 10 X-ray exposures in one HRCT, and therefore by proper guarding and with proper indications, I think a HRCT of the chest should not be delayed and denied to the lady.
Definitely, yeah.
Thank you. I think, Dr. Chatterjee, we've got a question from one of the audience, members. Her question is, which vaccine would you prefer for 5-month pregnant women, Covishield or Covaxin?
See, there is a marginal difference in the preparation of the two vaccines. But definitely, since this is a whole-killed virus vaccine, the Covaxin, I think I would prefer Covaxin over Covishield, because that's a vector-borne adenovirus vector-borne vaccine, the Covishield. And therefore, I think I would recommend Covaxin, which is available right now in our country. So the availability is in doubt. It's a big question. But if at all it is possible to get it, I think Covaxin would win over Covishield.
So, Dr. Chatterjee, have you got any slides to share, I believe?
I have been asked to talk on the antenatal care of the women in this COVID times. And it is definitely very, very important that our mothers are ensured safety during their pregnancy and during delivery. And therefore, over the 17 months of this COVID pandemic, I think most of our clinics, we have restructured our clinics, our OPDs, even in government or in private setups. And that is very, very important. What Sagarika has emphasized, that, online booking, pre-booking appointments, it is no longer a whole day affair where the lady comes with her tiffin, with her mother-in-law, mother, husband, and whoever is there at home. And it's a whole day program. It's nothing like that. Now it has to be a pre-booked appointment. There should be screening at the gate for each and every lady and her attendant. The clinic should be well sanitized, as we all know. This actually is for all kinds of patients, more so for pregnant ladies, because if once they get infected, then because they have to make certain visits to the hospital, others can avoid. But ladies have to come, pregnant ladies have to come to the hospital, and therefore we have to minimize the risk to the lady and also to ourselves. And therefore structuring of the OPD is very, very important. And we have to overemphasize on online consultation and online booking of appointments. That's very important. And another thing, the government of India has recommended, and all over the world now, we have reduced the number of antenatal visits to the minimum, unless it is, otherwise necessary for some complications or the other. So what we try to do is we ask the lady to present herself as soon as she gets pregnant or within the first 12 weeks, because that is the time when we pick up most of the problems that can occur. And that is the time when we are going to counsel her regarding COVID, what are the symptoms she can actually recognize, the early symptoms, and she can actually get back to us. We allay her fears. She definitely has some valid anxieties in pregnancy, because it is not only her, it is her fetus, herself, her whole family is looking forward to a bundle of joy. And so we have to allay her fears, at the same time make her aware that yes, this is there and you have to live with it. You have to live with your pregnancy, go ahead, but we are there and you have to follow whatever we are telling you. And another thing which I would like to tell all the mothers here and all our doctors who are watching, that club the physical examination, the lab test, imaging into a single visit whenever possible, so that she doesn't have to come back over and over again for all these tests. So therefore, integrate everything, all the examination, the lab test, the imaging in a single visit, and let her come back with the report online. Just don't encourage them to come back with the reports in the next visit after a week or 2 weeks or 3 weeks. No. And if she has anything to inquire, let it be online. So that way we can prevent any kind of cross infection to the lady and to our health staffs also. Second visit should be around 20 weeks when we go for the antenatal anomaly scan. Then again at 28 and 36 weeks, because we know these, as gynecologists and obstetricians, we know what is the importance of these kind of, this spacing of these checkups. Very, very important, because that is the time, especially at 36 weeks. If they can, go up to 36 weeks, we do a growth scan, we do a physical assessment, then decision making regarding the mode and time of delivery. So it is very, very important that we reduce the number of visits to the hospital. But suppose, see, this is regarding telemedicine. I put a slide I like this. So this is for you, that I want to overemphasize on teleconsultation as and when it is possible. Regarding patients who have been in contact with COVID positives at home, we should defer their appointments by at least 7 to 14 days, or unless and if the symptoms become severe, then maybe she will need admission. That is a different thing. Or any lady who fails to come for checkup for over 3 weeks, then we got to inquire. We got to contact her. And and if she is COVID positive or she has come in contact with a COVID positive patient at home, then therefore we recommend that USG for fetal growth can be deferred by 14 days. There is no hard and fast rule that even with a COVID positive lady, she has to come for an ultrasound scan. We can always allay their fears and recommend all these. Then we have to see the feasibility of isolation at home, as in all other COVID patients, and recommend accordingly. And if she needs termination of pregnancy or delivery, then preferably in a tertiary care setup, because we need a multidisciplinary approach in this kind of pregnancy with COVID. Regarding intrapartum care, before I really go into the intrapartum care, what are the things? What the 3 things which I would like to overemphasize here is, COVID itself does not affect the mode of or timing of delivery, unless there are respiratory conditions or very severe forms of the COVID infection in the lady, which will determine the mode or timing of the delivery. We can do some amount of instrumental delivery, like use of ventouse or forceps to cut short the second stage if the mother is hypoxic or exhausted. What are the places where cesarean section is recommended, or we have warranted cesarean section? Not in all cases. Only when there's severe illness, when the features of fetal distress, routine obstetric indications are there. There are many obstetric indications where cesarean section is called for, and if there's septic shock or if any kind of failure. So cesarean section is not the dictum in a COVID positive patient. In fact, cesarean can cause a lot of contamination in the operation theater. I think a safe vaginal delivery, because Shagrika has said that COVID virus has not been found in vaginal secretions, and so direct vertical transmission during delivery is not there as of now, and therefore it is safe to have a vaginal delivery in COVID infection with pregnancy. What are the assessments we do in labor room? Very, very important. We have to do a multidisciplinary approach. At the same time, the maternal, all the parameters, as Sagrika had said, temperature, respiratory rate, oxygen saturation is very important. Continuous fetal monitoring is very, very important. And do all the markers if necessary. Because, see, we have to rule out sepsis also. It is not always COVID, because now our mind, everything is focused on COVID. But everything is not COVID. If there's a temperature, it doesn't mean it's COVID. There are so many factors in pregnancy which can cause rise in temperature, like sepsis, like UTI, like some respiratory tract infection, like asthma, etc. So we have to rule those out. Then imaging can be done in severe cases to prognosticate. And if the patient has sepsis, do all the sepsis screen as per guidelines. Now, what I would like to say is, here, though it's given last year, see this delay in obstetric management should not occur if we cannot do the COVID testing. If a lady comes to our emergency and COVID testing is delayed, it is in our country, it takes RAT. If RAT is negative, we go for CBNAT or we go for RT-PCR, and that takes pretty long time. And women in labor cannot wait that long. So therefore, we start taking all precautions for our staffs and for the lady. We isolate her. We do a multidisciplinary approach, assess her, and positive till the report comes. That is very, very important. You keep on doing the management, taking her to be COVID positive in an institute where COVID patients are being treated, deliveries are being done, and delivery and management should not be denied just because the COVID report is awaited or she is COVID positive. So this is very, very important. And therefore, and the prophylaxis with antibiotics, thromboprophylaxis, these are very, very important points. And Sagrika has stressed on corticosteroids. That is also very important in maybe when she comes in preterm labor. Then the question of, though I have not included those in my slides, question of neuroprotection with Maxulf. That is very important because most of these ladies come with preterm labors. And Maxulf, neuroprotection with Maxulf is called for. And it is not prednisolone or hydrocortisone which we give as steroid in COVID, as such in COVID management, which will take care of the lung maturity, the fetal lung maturity. We have to give them betamethasone or dexamethasone. That is another message I would like you to carry today, because those are short-acting and these prednisolone, etc., get denatured in the placenta. They get metabolized in the placenta and they do not reach the fetal lung, which needs to get the steroid for fetal lung maturation. So these two are very, very important. One is steroid and one is the Maxulf therapy. So to prevent any neurological damage to the fetus. And regarding anesthesia, if you are interested, what is the best anesthesia? I would say regional, because general anesthesia does have its risk of spreading aerosol sprays. And if regional anesthesia can be given when the lady is in labor, and if she needs an emergency section, even that will take care of the operation. And therefore, it causes minimal spread of the COVID virus, and it's very safe.
Yes, we have a question. I think it's a very general one. I mean, like, which is better during COVID for a COVID positive mother, C-section or your normal route?
For any kind, I have told you that it's always there is that COVID is not going to decide the mode of delivery. But definitely, if the COVID is severe and the mother is decompensating, then definitely there is a case of emergency cesarean section. But as such, COVID is not an indication for cesarean section. And a safe vaginal delivery is what is always wanted in a lady. And because it offers less morbidity and its added benefits, rooming in, etc., the care of the baby is much better. The care of the mother leads less hospital stay, etc. So definitely, a safe vaginal delivery is something which is always wanted.
Dr. Chatterjee,
Yes.
one thing I would like to ask.
Yes, you are.
So, what are the guidelines for postnatal care for women and babies following a patient who has been affected with COVID-19?
See, regarding postnatal care, you should, if the mother is not severely ill or she doesn't have any high viral shedding at that time, I think rooming in is what is recommended even by WHO. But if the mother is severely ill and she has a very high viral shedding chance, then definitely we need to isolate the baby for some time. And if we cannot have a separate room for the baby, we can keep her in the same room, but with a 6 feet distance. And the mother can breastfeed not directly, but with a mechanical pump. She can take the milk, and there will be an attendant who will be a non-infected attendant who will take care of the baby from time to time. But if she's not severely ill, mild infection, then definitely taking all aseptic precautions and cleaning her hands, cleaning her nipple, cleaning her breast, and wearing a mask, keeping a certain distance from the baby, she can breastfeed her baby, and that is the best that can be advocated. But babies of mother with COVID positive should be tested at 24 to 48 hours with RT-PCR, and if positive, that should be repeated after 48 to 72 hours until 2 consecutive negative results. And as has been advocated all over the world, that the mother and the baby should go home after they test negative. But in our country, it is just not possible. So what we do, if they are asymptomatic, after 10 days, they're discharged after the thromboprophylaxis is over, and after we feel it is safe for them to go, unless severe forms of symptoms are there. Otherwise, we advocate them. If they are asymptomatic, we even discharge them without doing the second testing.
Yeah, one piece of information while I was going through today's newspaper, a baby born was found to be COVID negative, whereas her mother proved to be negative. Is that possible by any chance, or the test has to be repeated?
Pardon? Baby is negative, mother is negative. So what is the problem?
Baby is positive, but mother is negative. Newborn. In today's paper only. So I was this attracted my notice. So is there any chance of happening like that? Or maybe the test for the mother has to be repeated?
It's difficult for me to comment on this. I really don't know whether this is a false negative result, but definitely it has to be retested. The baby also has to be retested, and the mother.
Okay, right.
Somnatha, I would like to ask here, why, if the mother was negative, why was the baby tested in the first place?
I don't know. It just came in today's paper only. Why the baby was tested and why he has become positive and his mother negative. I don't know the reasons, but it read like this. When I was quite surprised.
I mean, if the mother, I think if the mother is symptomatic of usual COVID symptoms, then I think there is a ground of retesting.
Yeah.
Maybe.
Otherwise, why?
Yes.
At random to test we do not do.
Yes.
Another thing, which we'll soon move on, the interest of time to infertility treatment and COVID-19. But I think this is a question to both of the panelists is, Dr. Chatterjee, you spoke about steroids. And in some pregnant ladies, there can be a case of gestational diabetes. So isn't there added risk of complication of the blood sugar levels, going actually sky high after steroid treatment, even their short, active steroids? And what should be the optimum treatment for them, whether it's insulin or should they be put on oral hypoglycemics?
No, definitely we do a screening initially. First of all, taking history is very important. If they have a family history, strong family history, and then we do screen at the first antenatal visit and again at 28 weeks, we call them. And if suppose the lady is on steroids for her COVID treatment, we need to, first of all, she'll need hospitalization. She cannot be at home for this kind of treatment. And we'll have to do at least 5 times blood sugar monitoring in the hospital. And according to the sliding scale or according to the blood sugar level, we'll have to put her on insulin. Insulin is the safest in pregnancy and the outcomes are the best. And since she may get secondary infection, etc. And therefore, I think keeping the blood sugar under control is most important in pregnancy for safe outcome, to prevent preterm labor, to prevent infection, sepsis, chorioamnitis, and there's so many other added complications. And therefore, I feel blood sugar control is very, very important. And this steroid which is given in pregnancy in high dose, that's very short-term steroid. It is not a very prolonged steroid, and by the time usually they deliver, because if the mother needs steroid, then she's having severe symptoms, and if she's almost after 28 weeks or after 32 weeks, with the steroid rescue, we deliver the baby. So that is the thing.
Right, because there's another complication, I'm sure, like practitioners, because proning, which has been being sort of promoted, that, like if the SpO2 goes down below a certain level, so lie down in the prone position, which means lying on your stomach. So isn't that actually a physical barrier for women who are heavily pregnant?
That is what. That's why we actually take out the baby to prevent any mechanical effort on part of the mother, in addition to the already existing efforts which she requires in pregnancy. Pregnancy itself causes a lot of, the decrease in your tidal volume, in your lung capacity, etc., because of the mechanical effort effect of the baby, and secondly, because of progesterone. So therefore, taking out the baby at term, in early pregnancy, you can prone up to 24 weeks, 26 weeks, you can prone, even after 28, but you can make them lateral, when that improves. But proning at term, it's difficult, and therefore, if the mother is severely distressed, where the oxygen saturation goes down, then we need to terminate the pregnancy just to improve her respiratory efforts and outcome.
Thank you. So we'll move on to the second part, which deals with IVF, or in vitro fertilization, and assisted reproductive techniques. So, Dr. Sagarika, that during this COVID-19 times, what's the status of IVF? Should couples go for IVF, or, and what sort of precautions they should take? If you could just describe it in a series of slides, please.
So, yes, Dr. Bhaskar, during this pandemic situation, as everything else has been affected, the couples who require artificial reproductive treatment, their treatment has been affected considerably, I would say, especially in the initial stages of this pandemic, when as of now, we have got a little bit of experience or some studies available now. But if you remember about the lockdown period or the initial stages of the pandemic, nobody was actually sure, or there were very little studies or anything to guide us. And at that time, many of the ART clinics or the IVF clinics or the labs had closed down, and the treatments were significantly affected. So we have definitely moved on from that point, and we have slowly reopened or recommenced the IVF clinics in a stepwise fashion, which is very important. And we have started our the IVF treatments now. But the most important thing in the artificial reproductive treatment, or IVF, if we call it in a layman term, is that to understand for both the practitioner and the patient and her partner, that IVF treatment, first of all, it is not a life-saving treatment as such. So in this case, the patient information and counseling should form a very important part of our treatment. The patients and the couple should be given as much information as possible regarding COVID-19, regarding their status of treatment, what implications will they have if they contract COVID-19 during treatment, or what implications will they have if they contract COVID-19 if they become pregnant as a result of the IVF treatment. So all these things have to be discussed in detail. And then counseling should be done accordingly. There should be streamlined system of consenting, which we call informed decision making or etc., to help them to make their choice whether they want to carry on with their IVF treatment or they want to postpone it till later. So these are the very, very important things that we should keep in mind as clinicians. And that will help the patients as well, because with infertility, and especially with long-standing history of infertility, with the female's age, like advancing age, etc., these factors play a very important role in the couple's background as well. So there is a sort of rush in some couples. So it is very important to take everything on board before a commitment to IVF treatment is done. It is a completely different scenario in comparison to spontaneous pregnancy, because here we are planning and advocating a treatment to make a woman pregnant and the implications as such. Now, next comes the patient and the clinic staff assessment triage. So there are certain assessment criteria or a questionnaire which should be filled in, we should go through all these questionnaires at every clinic visit, before, at least 2 weeks before the treatment starts and before any procedures are undertaken. Sometimes we have to modify some of our services, and like as Dr. Shamapika said, for her antenatal care, we also, I mean, in infertility practice also, we have to redesign or revamp the clinic setup, etc., to minimize the chances of infection. As I said, that provide information helps to allay anxiety in patients. So in my first slide, I said that pregnant women are not at an increased risk of contracting COVID infection. And even if they do, majority of the patients will have mild symptoms. So this is a very important information which needs to be shared with the patient and her partner. And also some like information related to congenital abnormalities or birth defects in babies, or risk of miscarriage, risk of early pregnancy loss. So there, I already discussed that there has been no data so far which has shown any relationship of COVID-19 with all these things. So these has to be emphasized. So it forms a very important part of patient counseling. And definitely we have to emphasize at each patient contact how important the social distancing, physical distancing, hand hygiene, etc. I already talked about the consent procedure so that they can make an informed decision whether they want to carry on or want to postpone the treatment. And again, for our, like for the doctors who are present here, a clear documentation in the patient's note about all these discussions is very, very important for future references. It has been a common practice nowadays to test both the partners for COVID-19, either RT-PCR or NAT or some sort of testing before starting the ovarian stimulation and before any type of procedure in the ART clinics. So a lot depends on the result of this RT-PCR. If we get both the results negative, we are very happy and we are happy to carry on with our cycles. Couples are happy, doctors are happy, and we carry on. But the problem arises if one of the partners tests positive in any level of treatment. So that's when the dilemma starts. If we find out that any of the couples is positive before we haven't started the ovarian stimulation, it makes our life a little bit easier, that we can counsel the patient and we can postpone the treatment for maybe say 14 days or something like that. So we can postpone it for later. However, if we have already started the ovarian stimulation, and then at some point, because before each procedure, before an egg collection or what we call oocyte retrieval, we will again test them. And if they become positive at that point, what do we do then? Because we have already stimulated the woman. So the recommendation from ICMR is we cancel the cycle, and the same applies to the couples who test positive after their egg collection before embryo transfer. Now, in that case, if we have already collected the eggs and then they have turned positive, then we recommend that the embryos are all frozen for that cycle. And once their symptoms are, they become asymptomatic, they become RT-PCR negative, we do a frozen embryo transfer at a later date. So that is the usual recommendation.
Okay, that's quite useful information for couples who are going for IVF. Now, we have got a question for either of the panelists. Should low molecular weight heparin be used in COVID positive pregnant patients, and how long should it be continued for?
Low molecular weight heparin for pregnant patients, they have got certain indications. We do not start low molecular heparin straight away if we find a pregnant woman to be COVID positive. If she is hospitalized, and hospitalization may mean at some in some respects that there will be immobilization, so not much of mobilization in hospitals, and also the implications of COVID-19 on thromboembolism, etc. Yes, there is a role of low molecular weight heparin in pregnant patients if they are hospitalized, but not for everybody, not routinely. What do you say, Dr. Shamapika?
That is true, but in pregnancy also, for certain recurrent pregnancy loss, etc., we advocate LMWH. But for COVID per se, we do it under guidance in the hospital. And at that time, in certain patients where we have been using aspirin, low dose aspirin, that is to be stopped if the platelet count is low, because platelet count monitoring is as such not required when we give LMWH. But sometimes it is seen that in COVID with pregnancy that there is thrombocytopenia. In that case, we are supposed to stop the aspirin and continue the LMWH and continue it till delivery and after 10 days of delivery, because it is seen that post-natal also there's a high chance of thromboembolism. And we know COVID is a thrombogenic effect, pregnancy also is a thrombogenic effect. So these two together there's a high risk of thrombosis, and there is a chance of pulmonary embolism, etc., all the complications. And therefore, we advocate LMWH in hospital and 10 days before discharge. After delivery, we advocate LMWH. That is very effective and safe also in pregnancy, very much safe.
Right.
Is there any role post-COVID and post-delivery? Is there any role of dabigatran or apixaban?
If there has been no previous history of any venous thromboembolism in the patient, I don't think that we do. We don't, as obstetricians, we don't commonly use rivaroxaban or the DOACs, as we say. Usually, it is either low molecular weight heparin, or if there is a previous history of venous thromboembolism, etc., then after delivery we may shift to warfarin as well, usually. But DOACs are usually not for pregnant women.
I think this question keeps coming up. I mean, two of them actually. So I think we need to answer. I know we have all covered this topic, but there is still some lingering doubt. So firstly, that a lady who's pregnant and has got COVID-19, I mean, the use of antivirals, I mean, should they be discontinued, or, what should the patient or the doctor do? Either terminate the pregnancy, or, because the drugs cannot be given and it could take a more serious turn, or continue with Remdesivir or Fabliflu.
Early pregnancy, Remdesivir and Fabliflu are both teratogenic. And if it is an early pregnancy, then patient is on these two drugs, then we definitely need to counsel her for termination of pregnancy. But we try to avoid these drugs even at term pregnancy. But if it is required, because safety of the mother comes first, and in term pregnancy or after 28, 32 weeks when the fetal viability is there, when we can rescue the fetus, at that time, if there is a need, then maybe if the all these inflammatory markers are very much high, then Remdesivir or not Fabliflu. Fabliflu is absolutely contraindicated. There is a role of Remdesivir. in those cases, remdesivir has been used, and even in India, it's being used now in pregnant ladies, taking the benefits more than the risk, though it is contraindicated in pregnancy. That message should be clear that it is contraindicated, but to save the mother in those dire situations, we may need to reduce her morbidity. We may need to use remdesivir in those cases, but not routinely. And in early pregnancy, definitely it's teratogenic. It's a category D drug, and we are not going to continue with advise her to continue with pregnancy.
Okay.
So are we still on with remdesivir as per the latest ICMR protocol? Are we still on with it?
No, till now, right now they are saying that remdesivir does not have much to do with the outcome.
Yeah, remdesivir has come off the WHO list now, so it is not a recommended drug for COVID treatment anymore.
Yes, and I would like to add in that, there was a controlled trial done with remdesivir and ritonavir and flavipiravir and dexamethasone, the Solidarity trial, where it clearly showed that remdesivir, did not have any significant effect. In fact, it hardly had an effect, where corticosteroids were found to be more useful. We again are talking about a lot of tests, and I think amongst the doctors and the scientific community, we know what it means. But there is a question which that should any COVID-19 positive patient do D-dimer, serum ferritin, interleukin 6, and CRP? And if any one of our panelists could just explain that, what do these tests actually signify? What information does it give to the patient and to the treating doctor?
See, these are all inflammatory markers, and it can be done only to prognosticate the severe forms. What is the next step of management we are going to undertake? Whether we are going to give her IV steroids, whether we are going to give her some other antivirals, or what is the next mode of therapy that we are going to prognosticate, or any anti-monoclonal antibodies. So these are the interleukin monoclonal antibodies you are going to give her. That is the only thing. We are not going to do it in mild or asymptomatic cases. Only in severe forms, we can do these markers. And CRP is definitely a very important marker. It should be done even in moderate cases, because CRP can give you an indication that there is some infection in your body. And then we can exclude the others by testing. And therefore, I think IL-6 and D-dimer and ferritin are to be done in very selected cases.
I would like to add something here that, yes, there is a scope of doing all these tests, but in pregnancy, it creates a little bit of confusion and brings a little bit of dilemma as well, because pregnancy per se has got an effect on all these inflammatory markers as well. So in normal pregnancy, even D-dimer, and particularly D-dimer and CRP can become higher than the normal level. So definitely, yes, if the symptoms are severe, then we should be doing all these things, but interpreting the results, we should be a little bit careful that, yes, what is high and what is high for pregnancy. So that is a dilemma.
Excellent. So I think, with this, we can wrap it up. It was an excellent discussion, which we all had. And to summarize, we all know that COVID-19 is here to stay. It's not going away anytime soon. And with this, as we go through these different phases or these different waves of COVID-19, we are learning, we are evolving. And newer information is coming in, we would have more information to come on drugs which are recently going to, be actually approved, and more data is awaited that how we're going to move forward. So the idea is, pregnancy is a wonderful thing, but, one needs, I think the gist is that one needs to take appropriate care and precaution to make sure that firstly, don't contract COVID-19 as much as possible by following the protocols. And even if someone gets infected with COVID-19, it's not the end of the world. There are a lot of treatment options available. Consult your doctors to try to carry on as much teleconsultations as possible, so that, your physical exposure to the outside world is, minimized as much as possible. And we also learned from our panelists that, IVF, as Dr. Shagarika said, that's not a life and death issue. So if possible, postpone it. And if someone is already in the midst of going through the cycles, then, the sort of standard operating protocol, which Dr. Basu came up with, should be followed, and that should be of help. So extremely glad to have all of you on board, and all to our registration partners, like the people who participated in the seminar, for asking very relevant questions. I'm not here to announce another cyclonic wind this time, so hopefully we are safe. And so everyone take care of yourselves. And if there are any questions, you can always reach out to our Facebook page and, type your questions there, and we'll get our specialists to get in touch with you. So thank you very much. Thank you, Dr. Chatterjee. Thank you, Dr. Basu. Thank you, Dr. Kundu, for giving your valuable time. And until next time, take care. Bye-bye.
Thank you, Pacific, and thank you, Bhaskar. Thank you, Dr. Shamapika.
Yeah, thank you, all of you. We shared the chairs, and we shared all our opinions and myths and doubts we cleared. And thank you, Bhaskar and Dr. Kundu, for giving me this opportunity to present before you. And thank you all the audience for all your participation and active participation. I'll try to answer all your questions. And thank you, my students, for helping me prepare these slides.
And a big thank you to our team in Singapore, who is behind the scenes hosting this. So without their help, it wouldn't have been possible. So thank you, Joey.
Absolutely.
Okay. Bye-bye. Take care, everybody.